My name is Jessica Alvarez. I am one of the moderators for this session. And over the next 20 minutes, I will be speaking to you on body composition and Cftr modulators. Just for a brief introduction, I am an associate professor of medicine at Emory University in the Division of Endocrinology. And I will be occasionally monitoring the chat throughout the conference. So please feel free to contribute to the discussion there, or feel free to email me at jessica.alvarez@emory.edu. I have no disclosures specifically related to this presentation. So what I thought I'd do today was give you define and give you some rationale for why I think it's important to assess body composition in individuals with cystic fibrosis, but also to review the available literature surrounding changes in body composition following CFTR modulator initiation. And just a heads up, there's not that much literature because everything is still so new. So we know that body mass index is the primary clinical indicator of nutrition status in cystic fibrosis. And it's a great tool clinically because all you need is height and weight, and it's wonderful at catching people at the extremes of malnutrition and extremes of overnutrition. But somehow it has become sort of our absolute target for end goal for what defines good nutrition status. And it's true, BMI is positively associated with lung function, at least in children and adults, and at least up to a certain point. Several studies now have shown that there is a positive relationship between body mass index and lung function, but there seems to be a threshold where that relationship is no longer linear. It sort of starts to plateau, and that threshold has sort of changed over the years. So it's gone from 23 kilograms per meter squared to 25, and then the most recent one of the most recent studies out of Minnesota suggested there was a plateau at about 28 or 29, which is sort of shown here, where that relationship between BMI and lung function is no longer linear. So this tells us that it suggests that up to a certain point, increasing BMI may not necessarily improve lung function, at least at the population level. So the main issue is that BMI does not provide us with any information about body composition. It doesn't distinguish between the major metabolically active components of body composition, which are fat mass and fat-free mass. And then even with fat-free mass, we have more components within there, and there's muscle, bone, connective tissue, and even organs. On a positive note, BMI can be a useful surrogate for fat-free mass, but the problem is it also correlates with fat mass. What we're most concerned about when we think about longevity and health is the preservation of fat-free mass. So when we compare the relationship of different body composition components to clinical outcomes, oftentimes fat-free mass will perform better than fat mass or BMI. So, for example, in CF youth, lean mass measured by DEXA was a stronger correlate of FEV1 compared to BMI and fat mass. A study in COPD, chronic obstructive pulmonary disease, showed that fat-free mass is a stronger predictor of mortality compared to BMI and fat mass. And then a study in the general population showed that fat-free mass actually mediates the relationship between BMI and mortality. So that relationship sort of goes away whenever you adjust for or take into account fat-free mass. Several CF investigators over the years have reported a hidden depletion of fat-free mass in both adults and children with CF, that is having a normal range body mass index, and having a low fat-free mass. So I put together this table for you, that you can reference, but I wanted to highlight one of the more recent studies by my co-moderator, Dr. Ala Sheikh Khalil, that showed about a 27% prevalence of fat-free mass depletion among children with CF, in her Ohio center. And fat-free mass depletion has been shown, in addition to be associated with lung function, it's associated with recurrent pulmonary exacerbations, as well as increased pro-inflammatory cytokines. A lot of my work at Emory has looked at the other metabolically active component of body composition, which is fat mass. So here was a study in adults with CF showing significantly lower body mass index and lower fat-free mass compared to healthy controls, which didn't surprise us. We were expecting that. But percent body fat and fat mass actually didn't differ between the two groups, suggesting to us that there was a discordance in body composition in our adults with cystic fibrosis. We also found that just looking at the relationships, the cross-sectional relationships between lung function and body composition, not surprising, we found a positive relationship between body mass index as well as fat-free mass and lung function. But what did surprise us when we looked at percent body fat and looked at total fat mass, we actually found an inverse relationship. So higher fat mass was associated with lower lung function. And this actually had something that had been previously reported in the general population. Another way we looked at the data was to categorize adults with CF based on if they had a normal weight BMI, but had a high percent body fat. And so we called this normal weight obesity. And we actually found that about 31% of our study group, our adults with CF, had normal weight obesity. This was also associated with those with normal weight obesity also had lower fat-free mass, which did not surprise us. But also when we compared lung function between the groups, it was actually the group with normal weight obesity that had the lowest lung function. In a separate study, we looked at body composition with DEXA. So the previous study used BOD-POD. And this was a separate cohort. And these participants, we were comparing adults with CF compared to healthy controls. They were actually pretty well matched for body mass index. Their lean mass didn't differ and their fat mass didn't differ. But what did differ was visceral adipose tissue, in that our adults with CF had almost twice as much visceral adipose tissue compared to controls. So what did that mean clinically? Well, when we looked at the relationship between visceral fat and fasting glucose in the adults with CF, we actually found a positive relationship. So as visceral adipose tissue increased, fasting glucose increased. And we published that. More recently, we analyzed fasting insulin in these participants, and we similarly found a positive relationship between visceral adipose tissue and fasted measures of insulin resistance, so fasting insulin and HOMA. So as visceral adipose tissue increased, insulin resistance increased. In these same subjects, we also looked at hand grip strength, which can be considered a measure of muscle function. And for this study, while we actually did not find a relationship between hand grip strength and body mass index, but we found a pretty strong relationship between hand grip strength and lean mass. So again, this suggests to us that we should be studying body composition, because we would have missed this relationship if we had only looked at body mass index. And there are several methods that we can use to assess body composition, and they range pretty wildly as far as their clinical feasibility, as far as their cost, and even their accuracy. And I won't go through these body composition methods in this talk, but you should know that the key when using or interpreting body composition methods is understanding what the limitations are. So the Academy of Nutrition Dietetics formally recognizes the importance of body composition for CF health. So recent evidence-based nutrition practice guidelines from the Academy recommended that a nutrition status diagnosis should be based on a comprehensive assessment, and that includes body composition among a variety of other assessments. As far as which tools should be used, a consensus was made that when feasible, DEXA should be used since it's considered the clinical gold standard. But when not available, possible options to indirectly assess body composition might be mid-upper arm circumference or performing a nutrition-focused physical exam. Or skin folds or bioelectrical impedance analysis might be considered, with caution, acknowledging that these methods might underestimate fat mass and fat-free mass. The best ratings, however, that could be given to these methods of assessment were consensus or weak. This really was based on the very limited data that was available for patients with CF. As you heard from Juliana Bailey, we know that Cftr modulators are very effective at increasing BMI, and some of the mechanisms that have been proposed by Drs. Janan Stallings and others are decreased malabsorption, decreased gut inflammation, and decreased energy expenditure. But what effect do these modulators have on body composition? When we published this systematic review only last year, there were very few studies out there looking at body composition following Cftr modulator use. But since then, a few more have come out, and I'd like to spend the next few minutes highlighting some of these studies. So one of the more recent studies was led by Dr. Susanna King, and it looked at changes in body composition following initiation of Ivacafter in adults carrying the G551D mutation. First, it looked at a 28-day crossover placebo-controlled trial, and then it rolled into a 5-month open-label extension. And even in a subset of participants, it followed them over 2.5 years after Ivacafter. The study assessed body composition with bioelectrical impedance analysis. So results from this study, the overall findings were that there were acute increases in fat-free mass. So over the 28 days, there was a gain in fat-free mass, and that is represented right here, which was concomitant with an increase in total body water. By 6 months, however, the gains that were seen were in fat mass as opposed to fat-free mass. And so you can see here there was a significant increase in fat mass by 6 months, whereas there was no major change in fat-free mass. And the percent of weight gained by 6 months was actually 64% of it was in fat mass. By 2.5 years, at least in this subset of participants, it looked like everything had stabilized. So there were no further changes in fat mass or fat-free mass. Cumulatively, however, it seemed that the weight gain following Ivacafter was in fat mass. Dr. King published another study. This one was in 24 adults with delta F508 mutation, and it was an observation study of patients treated at least 1 year. Again, body composition was measured with bioelectrical impedance analysis. And what this study showed was that over 1 year, there was a significant increase in fat mass, which is represented here by these red dots, but there was no significant change in fat-free mass, which you can see here in this plot. So again, the weight gain in these in this particular population seemed to be fat mass, but not fat-free mass. So those are two of the most recent studies. And here's another reference table for you showing some of the other studies. So Burgard found no significant changes in fat mass or fat-free mass in a small study of mostly children. It was a young population, followed over a median of 15 months, and after Ivacafter use. Dr. Jean-Anne Stallings actually showed that there were significant increases in both fat mass and fat-free mass after Ivacafter use over 3 months. And this was a much wider age range of a population. And then Edgeworth and company showed in adults that there was an increase in BMI, but not fat-free mass following Ivacafter over 28 days. So the weight had to come from somewhere, maybe water, maybe fat mass. We're not actually sure. So to briefly summarize, while BMI remains very useful as a clinical monitoring tool, there are more robust measures of nutrition status, namely body composition and fat distribution assessment, that can add further insight into the progression of CF health and disease. There are multiple body composition methods available to use clinically, but although they do vary in cost and in accuracy, and it really is important to understand their limitations when you're reading about these studies and or doing your own studies. And the verdict is still out on what changes in body composition occur following Cftr modulator use. Adult studies suggested increases in weight were mostly due to fat mass gain as opposed to fat-free mass, but the results of other studies varied. So perhaps it depends on age or on genotype or how long we treat. And I like to end the talks usually with research needs to encourage nutrition research in this area. And this list is nowhere near exhaustive, but new studies, especially longitudinal studies, are needed to better define optimal nutrition status, incorporating validated body composition methods in CF populations. We need to determine what the long-term changes in body composition are following Cftr modulator use, especially with these new triple combination highly effective modulators. We also ultimately we need to gain evidence-based data to know how to optimize body composition with or without Cftr modulators, whether it's dietary supplementation, maybe protein, or exercise, or both. But really, evidence-based data is needed. Studies are needed to show these. So I'd like to end by thanking our wonderful study team and our Georgia CF Center that's been extremely supportive of nutrition research at CF, as well as my many collaborators outside of Emory, who I have the absolute pleasure of working with on a lot of these important questions. And so feel free to post your questions in the chat. Thank you.
Hello, everyone. My name is Candy Jump, and I'm a pediatric gastroenterologist at the Medical University of South Carolina. Thank you to the CF Foundation and the NACFC Planning Committee for inviting me to give this talk entitled Changes in the Bowel Pattern with Cftr Modulators. There are no relationships to disclose related to this presentation. Given our clinical experiences with Cftr modulator therapy, most in the CF community would say that cystic fibrosis-related GI symptoms of many kinds seem to improve with modulator therapies. But when we look for clinical data on improvement in GI function, there's a paucity, especially when compared to data on improvement in pulmonary function. Today, I'd like to discuss what mechanisms may be contributing to changes in the GI function of our patients. Most of what I'll be discussing is centered around the exocrine pancreatic insufficient patient, as these patients carry a large burden of GI dysfunction. It should also be mentioned that although much is known about the causes of altered motility and bowel dysfunction in CF, there's a lot that remains unknown, and the physiology is complicated with many intermingling causal and effect relationships. Although we are all familiar with the different Cftr modulators, this is a short description to help frame our talk. With the first 3 drugs on the market, Ivacafter alone and Ivacafter in combination with Lumacafter or Ivacafter, Cftr modulator therapy was available to about 50% of genotypes. The new triple combination therapy with Ivacafter, Ivacafter, and Ivacafter was approved in 2019 and is a Cftr corrector that binds to Cftr on a different site than Ivacafter. The addition of triple combination therapy to the arsenal of Cftr modulators has increased eligibility of Cftr modulator therapy to approximately 90% of CF genotypes. Because of the recent entry into the market of the last 2 drugs, Ivacafter, Ivacafter, and triple combination therapy, much of the current data assessing GI-specific outcomes of the Cftr modulators pertains to Ivacafter and Lumacafter Ivacafter. We have much to gain from understanding the effects of triple combination therapy, as this therapy expands the eligibility to 90% of CF genotypes. Abdominal complaints are common in CF patients. In this 2017 study, amongst 131 patients with CF, every patient reported at least one abdominal symptom in the prior 3 months. This included constipation in both adults and children, as well as symptoms that could be contributed to altered bowel pattern, like abdominal pain and distension. When we talk about the bowel pattern in CF, most of us likely think of constipation. And this is likely because we are also familiar with meconium ileus, which is a manifestation of the altered physiology that facilitates constipation in CF patients, and distal intestinal obstruction syndrome, or DIOS, which is thought to be a meconium ileus equivalent. And as we continue to use Cftr modulators, one outcome that we could measure and that has not been yet measured is the incidence of DIOS and meconium ileus with the use of these modulators. Another bowel pattern phenotype that exists in CF is IBS. This condition is defined by the clinical parameters listed from the Rome 4 criteria. In this 2019 study based out of the UK, the authors recruited 107 consecutive patients attending their CF appointment to complete a symptom survey in order to assess the burden of chronic or functional abdominal pain symptoms in CF. The cohort was comprised of adult patients with a mean age of 27.8 years, 88% of whom were pancreatic insufficient. Overall, 65% of patients described symptoms that would satisfy the criteria for IBS. This is much higher than the current prevalence of IBS in the UK, which was noted to be about 5.5%. In order to understand what may be occurring in the gut under the influence of Cftr proteins, Cftr modulators, it's important to know where in the GI tract the Cftr protein is located. CFTR is expressed at relatively high levels in the intestinal epithelium, with overall expression being highest in the duodenum and decreasing throughout the length of the small intestine and being lowest in the colon. Within the biliary tract, CFTR is located on both the intrahepatic and extrahepatic cholangiocytes. CFTR is located along the apical membranes of the secretory and absorptive cells of the pancreas, which is less commonly appreciated, CFTR is expressed in the central nervous system, specifically widespread in the neurons of the human spinal cord, as well as in the enteric nervous system in the myenteric ganglia. CFTR is also present within other cells in the GI tract, including lymphocytes in the lamina propria and submucosal blood vessels. The CFTR protein exerts its function as a cyclic AMP-dependent chloride channel, a bicarbonate channel, and a modulator of other ion channels such as the epithelial sodium channel. As part of the primary CFTR defect, patients with CF have reduced bicarbonate secretion from the pancreatic ductal, intestinal, and hepatic biliary epithelium, which leads to thickened secretions, poor hydration in the lumen, a more acidic environment, all of which contribute to intestinal dysmotility and the altered bowel pattern. Much less is known about how CFTR functions in the enteric nervous system. However, it can be co-localized with cholinergic neurons, and defects in CFTR have been shown to inhibit colonic muscle contractivity and acetylcholine release. Intestinal current measurement offers a unique way to measure the function of CFTR modulators directly in the intestinal mucosa. This 2018 study shows improvement in intestinal CFTR function in patients who were homozygous for the delta F508 mutation on lumacaftor ivacafter. Rectal biopsies were taken both before treatment and in the period of 8 to 16 weeks after treatment began. Intestinal current was measured and demonstrated a rescue of CFTR function to the level of approximately 18% of normal function. This increase in rectal CFTR function occurred without improvement in other parameters, such as FEV1 percentage or BMI. Pulmonary disease in CF has quantitative measures like pulmonary function tests, such as FEV1, which aid in the management and study of interventions like modulators. Unfortunately, no such outcomes have been used thus far for GI manifestations. So, apart from direct measurements of CFTR function in the GI mucosa, we can attempt to assess changes that CFTR modulators may cause by looking into the physiology that affects the bowel pattern. There are various proposed mechanisms for GI dysmotility in the CF intestine. This includes the primary insult being the CFTR defect and being responsible for the alteration in intestinal myenteric ganglion function and the enteric nervous system. Other mechanisms occur as the sequelae of the CFTR defect. These downstream mechanisms are interrelated, including a decrease in bicarbonate secretion causing viscous mucus, pancreatic insufficiency, poor micelle formation, and fat malabsorption, small intestinal bacterial overgrowth, dysbiosis with gut inflammation, and gut hormonal imbalances. The authors of this review postulate that the main insult is likely related to the defective CFTR in the enteric nervous system that could impair small bowel motility in response to abnormal intraluminal content resulting from the listed sequelae of the CFTR defect. To explore this a little bit further, let's first look at the mechanism of decreased bicarbonate secretion. Decreased bicarbonate secretion in CF causes an acidic lumen, which facilitates improper lipase activity, causing fat malabsorption. In addition, bicarbonate is also needed to hydrate the lumen, and without it, the mucus becomes thick and inspissated and contributes to poor motility. A potential mechanism for improvement in GI function would be an increase in bicarbonate secretion within the lumen. In this longitudinal cohort study of patients with the G551D gating mutation being treated with Ivacafter, the authors measured GI pH with a wireless motility capsule both at baseline and 1 month after treatment. The results show an increase in proximal small intestine pH and a decreased time to reach a stable pH of over 5.5, which is thought to be the ideal pH for pancreatic enzyme efficacy. This improvement in pH also correlated with weight gain. Overall, the author saw no change in the GI transit profiles before and after Ivacafter. So overall, small studies show that Ivacafter improves intestinal pH but does not alter transit time. And studies of this type with other modulators are lacking. Going back to the mechanisms for dysmotility, let's next discuss pancreatic insufficiency. Fat malabsorption is a multi-step process of emulsification, lipolysis, and solubilization, processes that require lipase and bile acids. This malabsorption plays a large role in the pathophysiology of constipation. The ileal brake theory hypothesizes that when the ileum of the GI tract senses lipid content, it will decrease jejunal motility through hormones such as peptide YY. The result is an increase in overall small bowel transit time. This is supported by the fact that DIOS occurs almost exclusively in patients who are pancreatic insufficient, with an increased risk when patients are non-compliant with their enzyme replacement therapy and thus have a higher degree of fat malabsorption. As it is believed that only 1 to 2% of residual pancreatic function is required to maintain exocrine pancreatic sufficiency, there exists a possibility that patients with borderline pancreatic insufficiency could be rescued by Cftr modulator therapy. Two ways to measure an improvement in fat malabsorption are through direct markers of pancreatic fecal elastase or through weight gain or increase in BMI. As the next talk in this session will be about modulators and exocrine pancreatic insufficiency, I will just say that Cftr modulators, including Ivacafter, Lumacafter, Ivacafter, and triple combination therapy, have demonstrated evidence of improvement of exocrine pancreatic insufficiency. An increased BMI can be seen with the use of Cftr modulators. And in fact, BMI is one thing that actually has been included in studies of many of the modulators. The weight increase that is observed under the therapies usually cannot be explained solely by regained pulmonary function, and it has been speculated to rely on improvements in GI physiology, such as an increase in bicarbonate secretion and fluid movement throughout the pancreatic duct and the GI tract, which helps to facilitate improved nutrient and fat absorption, overall decreasing obstipation and constipation, and increasing appetite, leading to increase in BMI. The 2017 New England Journal of Medicine study on triple combination therapy does show a change in BMI noted between the treatment group and the placebo group. It does seem that data support that Cftr modulators, including the new triple combination therapy, improve fat malabsorption when measured by increases in fecal elastase and BMI. Another mechanism for dysmotility in the CF intestine is poor micelle formation, which helps to facilitate fat absorption. Micelle formation is facilitated by appropriate production of bile by the cholangiocytes and flow through the biliary tree. Improvement in this process is supported by the increase in BMI, but what other evidence exists? There are reports of increase in fluidity and drainage of respiratory and sinus mucus by patients after starting Cftr modulators. This often leads to an increase in sputum production, sinus drainage, and cough, and has been dubbed the purge. Authors of this series report 7 patients who had symptoms of biliary colic shortly after initiation of triple combination therapy. All of these patients had previously been on a modulator. They were all pancreatic insufficient on a high-fat, high-calorie diet with the use of pancreatic enzymes. But not until they started triple combination therapy did they develop symptoms of biliary colic and, in some cases, acute on chronic cholecystitis. The authors suggest that a similar process to the purge occurred in the biliary epithelium, leading to changes in chloride and bicarbonate balance, restoring fluidity of bile through an increased flow in water, and that this change may have caused the movement of pre-existing gallstones and triggered the symptoms. So these cases show clinical evidence that Cftr recovery in the cholangiocytes occurs with modulators. Now let's discuss any evidence of improvement in gut dysbiosis and gut inflammation with the use of modulators. The GI tract harnesses many benefits from its commensal bacteria, which play a role in regulating metabolism and directing immunity. Literature also suggests that proper gut motility is dependent on the interactive forces between the microbiome, the enteric nervous system, and with the help of immune cells such as macrophages. Dysbiosis, which can be defined as a reduction in microbial diversity and a lack of balance between good and bad bacteria, is relatively prominent in the CF intestine. When this is localized to the small intestine, dysbiosis creates the symptoms of SIBO, or small intestinal bacterial overgrowth, abdominal pain, distension, flatulence, and altered bowel pattern, amongst others. Dysbiosis is also commonly encountered in the CF colon. With intestinal dysbiosis, there is an inappropriate immune response that leads to subsequent inflammation. Given that motility can be affected by the host microbiome and the immune response, measurements of change in the microbiome and intestinal inflammation with the use of modulators can serve as a marker of improvement in GI dysfunction. The dysbiosis of the CF intestine is precipitated by many factors: the acidic and dehydrated mucus, repeat and recurrent antibiotic exposure, the presence of dietary fat in the lumen, poor motility, and impaired bacterial killing by the innate immune system. The dysbiotic pattern is often dominated by an overgrowth of E. coli and a reduction in the bifidobacterium species. This study aimed to examine the effect of Lumacafter Ivacafter on inflammation in the bowel by looking at changes in fecal calprotectin. Fecal calprotectin is a sensitive marker for GI inflammation. The study was a retrospective study with data from 15 patients. Calprotectin measures were obtained within the 1 month before initiation of Lumacafter Ivacafter and at least 3 months after treatment initiation. In the graph on the left, you can see the mean fecal calprotectin before and after, which decreased from a mean of 713 to 102 with a significant p-value. The graph on the right shows a patient's individual changes in fecal calprotectin. One study examined the effect of Ivacafter on both gut microbiota and intestinal inflammation. The authors measured 16S RNA variable region amplicon sequencing and inflammatory markers such as calprotectin in 16 individuals with cystic fibrosis before and after Ivacafter. The median follow-up was 6.1 months. They found that fecal calprotectin was significantly decreased following Ivacafter from a median of 154 to 87. There was also a significant decrease in Enterobacteriaceae, which correlated with the decrease in fecal calprotectin. Thus, data does exist that describes a decrease in intestinal inflammation and a change in the fecal microbiome with the initiation of modulators. We do not have studies that show a direct effect in the changes in the enteric nervous system, ileal smooth muscle function, or gut hormone regulation, but more studies with GI-specific treatment outcomes are on the way. Because of the burden of GI disease in CF, a lack of specific outcomes to measure, the CF strategic vision for 2020 to 2024 includes the need for better research in gastrointestinal manifestations of CF. The Galaxy Observational Study is a unique collaboration amongst physicians, CF patients, and the members of the CF community to establish patient-reported outcome measures that accurately describe the GI experience amongst people with CF. The recently published study demonstrates feasibility and reproducibility of 3 different electronically reported patient outcome measures and stool-specific questions. The authors aim to create a tool that could be utilized for future CF trials. The PROMISE study, currently underway, aims to evaluate the effectiveness of triple combination therapy in people with 1 or more delta F508 mutations. The study will address the usual outcome measures such as FEV1, sweat chloride, and changes in weight and BMI, but will also collect additional GI-specific data, including laboratory data, wireless motility capsule data, and data from the EPROMs created by the Galaxy study. In conclusion, patients with CF have a high burden of GI symptoms, including altered bowel pattern that is dominated by constipation and IBS. We have some data about the effect of Cftr modulators on GI physiology that helps us to understand some improvements that we've seen, but there's a lack of GI-specific outcome measures in CF trials in general. Luckily, this will be changing soon as we all look forward to the results of the PROMISE study, which include GI-specific outcomes. Thank you.
Greetings. My name is Dinah Calnans, and I'm a dietitian here at the Hospital for Sick Children in Toronto. I wanted to thank the moderators of this session for inviting me to present to you today on CF modulators and exocrine pancreatic insufficiency. I have no relationships to disclose that are related to this presentation or that would present any conflict of interest. The objectives of the session today are to review the background of nutritional support practices pre-modulators and to describe the CF modulator's mode of proposed action on the pancreas as well as the gut. I will be presenting research and some case studies, case reports of modulator effects on pancreatic function and the gut, and will determine some guidelines on monitoring and evaluating pancreatic status when patients are on modulator therapies. Not that long ago, pancreatic insufficiency was thought to be a lifelong condition where the pancreatic function was thought to be irreversible due to the destruction of the acinar cells and a blockage of the pancreatic ducts. 72-hour fecal fat balance studies, fecal elastase, serum trypsinogens, steatocrit, and the mixed triglyceride breath tests were some of the tests used to determine pancreatic status. When it comes to elastase, I've shared with you here the guidelines for determining pancreatic status with less than 100 micrograms per gram of stool, indicating severe pancreatic insufficiency, 100 to 200 as moderate pancreatic insufficiency, and greater than 200 revealing a normal pancreatic function. In this publication by the late Dr. Peter Dury and colleague Dr. Gordon Forstner, they shared this pancreatic pathophysiology in cystic fibrosis and outlined here the pancreatic acinar cells and the ducts and how it differs in health and in cystic fibrosis. The stimulated acinus in a normal pancreas produces fluid that is rich in enzymes and proteins, and there's a fluid flow that's mediated by anion secretion. In the bottom cell, you can see, which is the CF cell, the fluid becomes more dehydrated and enzymes eventually block the cells, resulting in a destruction and atrophy of acinar cells and their ducts. Treatment for pancreatic insufficiency includes oral pancreatic enzymes with varying efficacy, requiring an individualized approach to treatment. Adjunct therapy, such as PPIs, are sometimes used to enhance enzyme efficacy with variable evidence and increased nutrient maldigestion and malabsorption. And there's a trial going on currently in the US that will hopefully answer this question in terms of the efficacy of using PPIs and enzyme therapy together. There's a variable response again to enzyme therapy due to multiple factors affecting nutrient maldigestion and absorption that include lack of or a variable pancreatic enzyme productivity, variable diet and timing of enzyme dosing, the lack of bicarbonate production, both pancreatic and proximal small intestine, and as a result, the altered pH in the small intestine, which affects enzyme activity. As a result of that as well, you'll have bile acid precipitation, which results in poor micellar formation. The mucin production, with the fluidity of which is affected by a more acidic environment, interferes with nutrient absorption. Intestinal inflammation can result from increased mucus production, a disturbed motility, small bowel overgrowth, and inflammation all interacting. And there could be, as a result of all this, a microbiome dysbiosis, which we'll also be presenting later on in this talk. In terms of determining the response to oral pancreatic enzyme therapy, this includes assessing and monitoring a patient's nutritional status using anthropometrics and body composition, if that's available in the organization, looking at nutrient maldigestion and absorption using either 72-hour fecal fat, breath tests, steatocrit, serum fat soluble vitamin levels such as vitamin E, maybe other vitamin deficiencies, and also monitoring any GI disturbances that might include loose or frequent stools, oily stools, a change in these that's really assessed and based on the individual patient, and other symptoms such as reflux or feeling full, constipation, DIOS. In terms of the mode of proposed action of modulators, the CFTR mechanism is dependent on tissue and cell types in those affected by CF. They're very high in most ductal epithelial cells in the pancreas, and CFTR is expressed in intestinal epithelial cells. Modulators support the clearance of pancreatic ducts, resulting in an increased fluidity of the protein secretions, the acinar cells producing enzymes. There's an improvement in the abnormal intestinal pH with the secretion of bicarb, decrease in inspissated mucins within the intestinal crypts, and all these can improve the gut microbiome and the degree of inflammation. This cartoon depicts the different modulators, Ivacafter being a potentiator, which increases the gating and conductance of Cftr channels that are present at the cell surface. Lumacafter, a corrector, which increases the number and function of Cftr channels at the surface. And the combination of Ivacafter and Lumacafter, which would increase the number and enhance the function of Cftr channels at the cell surface. Getting into the research on modulator therapy, Dr. Drusi Borowitz et al. Reported in 2016 on the Ivacafter study. They had 213 patients enrolled, 105 were less than 20 years, and 108 were greater than 20 years of age. It was a multi-center trial. They did observe improved nutritional status after 48 months with improved weight Z scores and BMI Z scores. This implied that pancreatic function had improved, but they didn't measure pancreatic function in terms of fecal elastase in this study. There was no correlation between improved nutritional status and lung function in this study. They also had a CF questionnaire, which revealed an improved perception by patients of their eating, of their body image, and the ability to gain weight. From that study, this is the significant mean change in body weight at 48 weeks, comparing Ivacafter group to placebo in those less than 20 years, and a similar type of graph was observed in those greater than 20 years. The Kiwi study, another Ivacafter study, was in 34 patients aged 2 to 5 years. It was a multi-center trial, 24 months in duration, and this was reported by Davies et al. In Lancet in 2016. Their primary outcome of the study were safety and pharmacokinetics, and the secondary outcomes included nutritional status. In this study, they observed significant improvement in BMI Z scores, and 41% of those that had a fecal elastase demonstrated a level that was greater than 100 micrograms per gram during the course of the study treatment, and 37% of these actually showed no improvement in fecal elastase. And this graph from that study depicts the variable response and the improvement in some or no improvement in others. And we can see that at baseline, they were below 100 cutoff for fecal elastase. In the Arrival study, this was a phase 3 multi-center study looking at patients the age 12 to less than 24 months at enrollment. This was again assessing safety of modulators in younger children. They did observe improvements in fecal elastase and in trypsinogen concentrations together with lipase and amylase, which supported the potential of Ivacafter to protect against progressive exocrine pancreatic dysfunction. And there was evidence that Ivacafter, if started in infancy, might protect or minimize the pancreatic and the airway damage later on. And this study was by Rosenfeld et al., reported in Lancet Respiratory Medicine series in 2018. And from that study, you can see from the two top graphs an increase in fecal elastase represented for each patient and their mean values. And there was a rapid improvement noted. And then on the bottom two graphs, this is the decline in trypsinogen represented for each patient and their mean values. And of note, IRT is expected to decline with age. In the Arrival study, for looking at Ivacafter, this was a phase 3 study looking at patients 4 to less than 12 months of age at enrollment. And they were assessing the safety in modulators in younger children, 24-week duration of study. And this was reported by Davies et al. Just this year in 2021. At baseline, patients had a normal weight and they had normal length parameters. And what they observed is depicted here with an improvement in fecal elastase in the green triangles, and IRT, lipase, and amylase actually also all declined. And there's also a depiction here for the different ages. So I'm sorry, the green triangles are 6 to less than 12 months, and the blue circles are 4 to less than 6 months. And we're observing the mean change in fecal elastase. Now, going on to some case reports in this study, in this report by Magala et al. In 2019, they report on a 10-year-old who was on Ivacafter for 4 years. The history is that in infancy, this patient had greasy stools. They didn't have an elastase performed, but the stool was positive for fat stain. At age 6 years, the patient was started on Ivacafter. At age 10, was diagnosed with severe pancreatitis. A fecal elastase was done at that time, revealing values in the normal pancreatic function range of 500, 500, and 376. They reduced the enzymes by 1/2 and then discontinued them after 4 weeks, and this patient continued to gain weight. And the authors state that this case presented represents the first known case report of complete recovery of pancreatic function in a patient prescribed a Cftr modulator. Then Howlett et al. Also reported in 2016 for a patient who was 4 years and 9 months diagnosed with a fecal elastase at the time of less than 15. This patient was treated with Ivacafter for 6 years, and after 6 months of therapy developed abdominal pain and constipation, so they reduced the enzyme dose by 50%, and they performed another fecal elastase, which came back normal at 259. After 7 months therapy, fecal elastase was again repeated and revealed levels in the moderate to insufficiency range of 118 and 121. And this demonstrates the fecal elastase concentration and the change in percent FEV1 in the top graph, with the bluer, lighter blue triangles being fecal elastase, and the bottom graph demonstrates the change in BMI z-scores during the 6 months treatment time. The top was 7 months treatment. In another case report by Smith and Raymond in 2020, they shared that they had a 2-year-old with a fecal elastase less than 15. Ivacafter was initiated for this patient at 12 years of age. And 2 years later, at 14 years, the patient was less compliant with enzyme therapy, which we often see in those patients who are on modulators. And eventually, this patient discontinued them by age 17 due to an absence of any abdominal symptoms. Growth was good with a BMI of 43%, height at 99%, and the fat-soluble vitamins were in the normal range. They repeated a fecal elastase, which came back at 263 at 17 years of age, indicating normal pancreatic function. Pope et al. Presented on a study with Ivacafter in patients who are pancreatic sufficient, and on Lumacafter, Ivacafter in pancreatic insufficient people with CF. Their outcomes included fecal measures of malabsorption using elastase and steatocrit, and fecal microbiome. They found there was no statistically significant fecal changes with either treatment. They did detect trends in the PI cohort towards a decrease in fecal fat content and towards fecal microbiomes that more closely resembled the fecal microbiota of people without CF. And from that study, we can see on the left-hand side the two graphs looking at fecal elastase. In the far left graph are those who were PS, so we wouldn't expect a change in treatment. And on the right-hand side was the patients with PI. And again, there was actually no change in their elastase in this study. On the right-hand side is the percent fat per gram of feces. You could see the variable response and pretty normal values in the PS group. And then in the PI group, you can see that post-treatment, there was a decline in this value. In this study by Keith Uwe et al., changing direction a little and looking more at inflammation, so the microbiome, Ivacafter, they stated improves inflammation by reducing calprotectin and improving microbiome, resulting in an improved intestinal milieu, supporting normal gut microbiome and thus decreasing inflammation. And this was done in 16 children and adults with CF. The GI, I wanted to share this study by Hayden et al. That was reported in Nature as a letter in 2020, where they discussed the GI microbiome, which is associated with growth in infants with CF. And in this study, they suggested that the intestinal dysbiosis may alter potential for height achievement in infants with CF due to the effects on endocrine function. A delay in development of fecal microbiome compared to controls was observed. The effect of microbiome, they concluded, may influence growth, and the correction of Cftr through modulators may actually influence the gut with less inflammation, improve motility, and thus affecting the microbiome. I'm sharing some guidelines with you that came out this past summer from CF Canada, looking at what the frequency of monitoring fecal elastase in patients who are on modulator therapy. We know that the time to PS from PI can range from the studies and case reports shared from 6 months to 7 years, and depending on, of course, the age at start of therapy. And the recommendations or guidelines here are to measure fecal elastase as a measure of pancreatic function in the initial visit, and then again at 3 months, and then at the 1-year visit. So, conclusions and recommendations. There are some data suggesting that CF modulators can have a direct impact on improving and correcting pancreatic enzyme production and on improving small intestinal milieu, resulting in this improved nutritional status in some patients. More research is required to help guide on when to reduce or discontinue oral pancreatic enzyme therapy, and to distinguish from early and later start of therapy is an important factor. Consider maybe more frequent monitoring of fecal elastase for those beginning treatment less than 12 months of age, and monitor for signs of pancreatitis as a result of improving pancreatic function. And there's a Canadian study in press on this topic. An individualized approach to reduction of oral pancreatic enzyme therapy would be advised, with routine measurement of fecal elastase, serum trypsin, though we expect that to decline with age, continued growth and weight monitoring and body composition, monitoring serum fat-soluble vitamin levels, and albumin. Consider a gradual enzyme therapy reduction before complete discontinuation, even if the fecal elastase are approaching more normal values. I thank you very much for your attention, and I look forward to hearing your questions and hearing from the rest of the speakers. Thank you very much.
Hi, my name is Juliana Bailey, and I'm the Registered Dietitian and Quality Improvement Coordinator at the University of Alabama at Birmingham Adult CF Program. Today, I'm going to be speaking to you about the nutritional and metabolic effects of Cftr modulators. I have no disclosures to report related to this presentation. So I wanted to start off by giving some background on nutrition and cystic fibrosis. Most of us are familiar with the fact that malnutrition is one of the most common clinical features of CF. In fact, cystic fibrosis used to be known as CF of the pancreas, and this is because CF mortality was due to malnutrition before pancreatic enzyme replacement therapy was available. So historically, nutrition therapy involved a low-fat diet to control steatorrhea, but in 1988, Corey and colleagues found that patients at the Toronto CF Center had a significantly longer life expectancy than patients at the Boston CF Center. And the main difference between these two populations is that people in Toronto consumed a high-fat diet compared to people in Boston who were consuming a low-fat diet in order to control their steatorrhea. So this is what led to the classic CF diet recommendation of eating high-calorie, high-fat, high-protein, and high salt. Not a whole lot of evidence for that diet recommendation. But the landscape of nutrition and CF is changing. You can see here from these graphs that I pulled from the CF Foundation Patient Registry Report for 2019 that BMI is improving in both children and adults with CF and has been improving steadily over the past 10 years. With improvements in care, treatments, and extended lifespan, CF comorbidities have become more pronounced, and we're now seeing the entire spectrum of nutritional status from malnourished all the way up to overweight and obese. And we know from another CF Foundation Patient Registry report that the proportion of people with CF who have malnutrition is decreasing, whereas the proportion of patients who have obesity and overweight in both the pediatric and adult populations has been increasing over time. So we're really in uncharted territory, and the best practice for nutrition in the setting of these changes is unknown. Cftr modulators are the first drug treatment to treat CF at the cellular level, and they are one of the main contributors to this improvement in longevity and potentially to nutrition status. So I wanted to spend some time today reviewing the evidence for each modulator and its effect on nutrition and metabolic parameters. So I'll start with Ivacafter because it is the oldest modulator, it's been out for the longest. And clinical trial data showed that adults with at least one copy of the G551D mutation gained weight on Ivacafter, as well as children. Children also experienced improved linear growth on Ivacafter. There was no significant effect on fat-free mass in adults with the G551D mutation. However, this was only examined after 4 weeks on the drug. There was also no significant effect on weight for age and BMI Z-scores in children who took Ivacafter but were homozygous for delta F508. And the effective BMI was not significant in adults with at least one copy of R117H. Recently, Dr. Gimbalot and colleagues studied the long-term effects of Ivacafter in pediatric and adult patients who had been on the drug for over 5 years. And what they found was that overweight and obesity increased with long-term Ivacafter treatment. You can see from this graph here that overweight increased by 9% in both pediatric and adult populations, whereas the proportion of children who were obese remained stable. We saw a 3% increase in obesity in adults who took Ivacafter for 5 or more years. You also will notice that the proportion of underweight decreased in adults who took Ivacafter, and that decrease was about 7%. So Dr. Stallings and her group have studied the mechanisms of weight gain on Ivacafter, and they enrolled adults and adolescents who had never taken Ivacafter. They took some baseline measurements, and then they did some follow-up measurements at 3 months. And they found significantly decreased resting energy expenditure by 5.5%. So people were using less energy once they started taking this drug. They also found improved absorption and decreased gut inflammation, and postulated that all of these things could be mechanisms of weight gain observed on this drug in adults and adolescents who have gating mutations. Another group also examined dietary intake changes on Ivacafter. They enrolled a group of Italians and a group of North Americans and did comprehensive diet records both before and after the participants started taking Ivacafter. You can see on this graph on the left, this is the estimated energy requirements here, and the dark boxes are before Ivacafter and the lighter boxes are after. You can see in Italians that they had significantly increased caloric intake over the course of the study, whereas North Americans did not have any significant increase in calories. They also examined fat intake and found that both Italians and North Americans had increased intake of fat over the 3-month study time period. It should be noted that Ivacafter has to be taken with a fat-containing food, so that might be one reason that we saw increased fat intake, even though calories stayed stable. I wanted to speak a little bit to absorption in Ivacafter as well. So importantly, pancreatic insufficiency contributes to growth failure, vitamin deficiencies, and can even contribute to osteoporosis in adulthood. Because of the early and severe onset of pancreatic dysfunction in most people with cystic fibrosis, it seems unlikely that this aspect of the disease would be reversible. However, some investigators have reported a degree of reversibility of pancreatic dysfunction in infants and young children. So I have pictured here a figure from the Kiwi and Climb study. And you can see that at the start of the Kiwi study, about 6% of participants had a fecal elastase of greater than 200, which would indicate pancreatic insufficiency, so a very small percentage. And by week 84 of Climb, that had increased to 35% of children who had a fecal elastase greater than 200 or who had become pancreatic sufficient. Also in Kiwi, IRT levels decreased from baseline to week 24, suggesting reduced pancreatic inflammation and stress from when they entered the Kiwi study, and this decrease was also maintained throughout Climb. So Kiwi and Climb assessed patients on Ivacafter only and who were pediatric. There's been limited assessments of absorption changes in adults on modulators, but Stallings and her group found that fecal elastase improved only in the pancreatic sufficient adults with gating mutations who were taking Ivacafter. No significant changes were noticed in adults with pancreatic insufficiency taking Ivacafter only. So there's obviously the most evidence on Ivacafter. It's been around the longest, been studied the most, but it's also approved for the smallest amount of people with CF, only 6% of the CF population. The next modulator that was approved was Ivacafter Lumacafter, and this was for any patients who had 2 copies of the delta F508 mutation, so about 50% of our CF population. So in clinical trials, effects of BMI were mixed in adults with class 2 mutations. There was no effect on BMI in children who were homozygous for delta F508, and there was increased BMI observed in adults who were homozygous for delta F508. However, baseline nutritional status was not reported. The effect of treatment on body composition and dietary intake were not described in any of these trials. And then we have Ivacafter and tezacaftor. There was no significant change noted in BMI Z-scores in children homozygous for delta F508. There were also no significant changes for adults and children who were heterozygous for delta F508 with residual function mutations. Again, the effect on body composition and dietary intake are unknown because they were not studied in these trials. So now moving on to Elexacafter, tezacaftor, Ivacafter, or ETI. This is the newest highly effective Cftr modulation therapy drug. And in clinical trials, we saw an improvement in lung function and quality of life, and also significant improvements in body mass index and BMI for age Z-scores in individuals who had either 1 or 2 copies of the delta F508 mutation. So there are several observational cohort studies going on to assess the outcomes of ETI and the clinical setting long-term. These are the Begin, Recover, and the Promise study. Promise is a multi-center observational cohort study. It also has a GI sub-study that's assessing absorption on ETI. I'm sure you'll hear more about some preliminary results from that study later in one of the other symposium talks. There's also an endocrine sub-study that's examining body composition. And then we did a single center nutrition sub-study at UAB to assess energy expenditure, dietary intake, and hand grip strength. So in our nutrition sub-study to Promise, and that's abstract and poster 216, also presented in the nutrition research workshop, we were able to enroll 22 adults and adolescents who had 1 copy of delta F508. Half of our participants had 2 copies of this mutation, and we had 17 participants who completed all 3 visits on our study. We had a baseline visit before participants took the drug, and then we did a short-term follow-up at 28 days and a long-term follow-up at 10 months. And we found that mean BMI improved significantly by 0.96 kilograms per meter squared at greater than 6 months. We also found a significantly decreased resting energy expenditure by 6.6%. This is consistent with what was observed in the Ivacafter study. We also noted increased calorie and fat intake over the course of the study. And there was a healthy eating index score of 52 at baseline. This did not change throughout the study. And the healthy eating index score, briefly, is a validated measure of diet quality based on the dietary guidelines for Americans. It's a scale of 1 to 100, with 100 being the highest possible score, indicating the best diet quality. And just to give you sort of an idea, the adult general population in the US has an average healthy eating index of 59, and that's based on NHANES data. So the healthy eating index score in our CF sample was similar to the general population, but also indicates very poor diet quality that did not improve over the course of ETI therapy. There were also no significant changes to protein, carb, or micronutrient intake or pancreatic enzyme replacement therapy dosage through the course of our study. So now that I've given you an overview of the nutrition and metabolic effects and what the research says on that in Cftr modulators, I wanted to also provide an update on some new CF nutrition guidelines. There's been a lot of talk in the community about how new guidelines for nutrition are needed and recommendations for the CF diet are outdated, especially given all of these changes and in an era where 90% of the CF population is on highly effective modulator therapy that causes weight gain. So the Academy of Nutrition and Dietetics Evidence Analysis Center conducted a systematic review of the literature to develop an evidence-based practice guideline for primary nutrition issues in cystic fibrosis. And this guideline is designed to complement and build upon existing evidence-based CF nutrition guidelines, such as the Australia and New Zealand guideline that came out a couple of years ago. So the consensus recommendations for diet therapy in CF that are updated were to recommend an age-appropriate healthy diet that emphasizes culturally appropriate foods associated with positive health outcomes in the general population. So this is very different than the typical high-calorie, high-fat recommendation. The consensus statement went on to say that diet prescriptions should be individualized for dietary preferences and nutrient needs, and the recommendations should promote consumption of nutrient-dense foods, including healthy fats and micronutrients. And finally, the recommendation was to supplement with energy and or protein-dense foods, oral or enteral supplements as needed to achieve and maintain normal growth in BMI. And this last recommendation was really put in there because there is a percentage of patients who are not eligible for highly effective Cftr modulation therapy. And we do have a percentage of patients who will still struggle with malnutrition in CF. So we try to be inclusive in these recommendations and sensitive to that. And during the systematic review and creation of these guidelines, there was no evidence to suggest that modification from a well-balanced general healthful diet is associated with improved outcomes in adults or children with CF. So, in conclusion, Cftr modulators' impact on growth and anthropometric measurements is dependent on both the modulator formulation and the individual's genetic mutation. Cftr modulators, some of them anyway, may decrease energy expenditure, so calories might need to be decreased in order to avoid excessive weight gain and some of the health risks that go along with that. Best practices for dietary prescriptions and adjustment of pancreatic enzyme replacement therapy in the setting of modulators is not known. And CF BMI goals must be reevaluated given the trend of rising BMI, poor diet quality found in some of these studies, and increased calorie and fat intake noted on ETI. Updated nutrition guidelines emphasize dietary prescriptions that focus on nutrient-dense foods and a general healthful eating pattern modified to the individualized needs of the person with CF. There really is no more one-size-fits-all CF diet. And this is where the registered dietitian on your team can really shine and help with co-producing individualized nutrition care plans for patients with CF. And finally, more research is needed on how dietary intake may modify the relationship between Cftr modulators and nutrition status.
Hi, everyone. Thank you so much for tuning in to the symposium. My name is Ala Sheikh Khalil. I'm co-moderating this session with Dr. Jessica Alvarez. And we are so excited to have been able to deliver these great talks from all of our speakers on the effect of highly effective modulators on the GI tract and nutrition. We have gotten some really great questions, and we would like to get started on the question and answer session. I think one of the comments that we got that resonated with me as well is that a lot of the information that we're getting now is still in progress. We're still waiting on the results of the PROMISE study. You still need to think about individualized approach for all your patients, and we want to avoid over-interpreting results for specific people. But nonetheless, we can't help but be very excited about these medications. So I'm going to start with you, Jessica. And one of the questions we had for Dr. Alvarez was, do you worry about how focusing on body composition might result in unnecessarily poor body image as we communicate results to patients?
It's a great question. My thought goes to sort of the inverse in that if we start focusing on body weight and body weight gain, that to me I start thinking negative thoughts. But if we focus on the inverse, the healthy, so how strong are you? How much muscle can you build? That kind of shifts the focus to a more positive relationship with body composition, not just this focus on weight, which could mean nothing.
Right. And thinking about, fat mass and fat-free mass, when we have excessive fat, it's more, I think of it more as a fat-free mass deficit rather than an increased adiposity in and of itself, right? So we can focus the discussion, just like you said, on we need to work on fat-free mass.
Right. Shift it, make it a positive way to change habits.
Yeah, it's great. And then the other question, we got two questions that had a similar theme. One was, have you noticed that people who undergo dietary counseling and increase in physical activity have different outcomes with the body composition with modulators? And related to that, the question is it time to start encouraging people with CF even more focus on physical activity and resistance exercises, similar to recommendations for other?
Yeah. So I'll start with question 2. I was actually at an exercise and PT session yesterday, and yes, it is time. That one of the main outcomes that I got out of that session was that we need to start thinking about exercise prescription, not necessarily, also in addition to lung function, but for long-term cardiovascular and metabolic type health. Simultaneously at the CF conference is the Obesity Week conference. And so I've been attending both. And another session that I was at suggested it's not going to be dietary changes that we need to do. For any sort of metabolic health, we need to do both exercise and diet. That's what's going to lead to changes. So the time to start focusing on both diet and exercise is now. As far as clinically what we've seen, I want to direct that question to Dr. Bailey, seeing if any of her patients have done that, because right now the studies are not out. We just don't have any published studies, but there might be some more case reports that are available.
Could you repeat the clinical portion of the question about diet?
Have you noticed that people who've gotten specific individualized diet and exercise prescriptions had different outcomes with regards to their body composition changes with the modulators?
Go ahead. We are only measuring body composition at our center using skin fold measurements, and we often do track that for patients who are starting an exercise regimen. And we definitely do see changes in body composition when we give those individualized exercise plans for building lean body mass, in addition to counseling for more of a general healthy diet, particularly if patients have seen this unintentional weight gain on modulators. That's speaking to the clinical experience. Like Jessica said, there's not a whole lot of published data on that right now.
Great, great. Thank you. And we still have more questions for Dr. Alvarez, and we'll come back to them. I'll move on a little bit to Dr. Jump for a couple of questions. One question that came for you was, do we think that the intestinal dysmotility that we see in people who have CF is reversible, or are people meant to stay on medications such as, say, Amitiza for the rest of their lives?
That's a really great question. I wish I had a really great answer. We still don't know a lot, but and there's just limited data. Some of the data we have, which is really smaller patient numbers, shows that we can change the pH and we can change the bicarb, but maybe we don't change intestinal transit time, right? So we definitely need some larger scale studies with these newer drugs to look at it. And perhaps if we change that Cftr dysfunction in the GI mucosa, we can do it at the mucosal level, but maybe how Cftr functions in the enteric nervous system is different, and we have less effect on that. We just really don't know. I guess I'm just really hopeful that if we can change things like pancreatic function, that perhaps we'll see more of dysmotility reversed. I mean, I think we see some of that even in non-CF patients, where they can have periods where their GI dysmotility is more affected than others. And so I'm hopeful that we can see it, but I don't know that we have enough information to say that it's reversible long-term.
Okay. And then another question that had come up, and we had talked about it briefly in the green room before the session, is, have you seen what the person who asked the question called it onboarding symptoms? I like that. For example, are we seeing gas, pain, like constipation as people are starting? And then the person asked a follow-up question in terms of, do you think that there may be differences between pancreatic sufficient and pancreatic insufficient people, and how their GI tract is affected by these drugs, at least in the beginning?
Yeah, I mean, I think there's a lot that goes in, I focus mostly on the exocrine pancreatic insufficient patient, mostly because I think the modulators have, greater room to improve their GI tract function there. So I do think that we're going to see different changes in the exocrine pancreatic insufficient patient, more so perhaps than the sufficient patient. And I agree that I do also like that onboarding sort of way to describe it. So yeah, there can be some worsening of the GI tract functioning there. And I don't think we know exactly what's going on, but I think maybe we're seeing something similar to that purge that we sort of talk about in the lungs, and the purge that we talk about in the biliary tree. And maybe there is some mismatch or imbalance in the chloride and bicarbonate secretion that perhaps isn't accompanied by the increase in motility or the increase in fluidity initially, and that it takes some time after onboarding where we really get to see the system, the milieu, sort of get back to a new baseline where we can have all of those things happening at the same time. Yeah.
Great. Wonderful. And again, I do have some more questions for you. I'll come to them. I'll come back to you in just a little bit. Dinah, you also got a lot of questions, and the themes were a couple of things. One is, how do we start to remove the enzymes? Do we start to reduce the doses? How often should we be monitoring stool elastase on people who are starting modulators?
What a great question, Ella. And as others have said, we're going to need a little more data, and I'm thrilled that we're all looking for data to create our guidelines and not just look at anecdotal cases. But I think the guidelines that CF Canada came out with were nice to see, that you do a baseline 3 months and a year, so that if you do have somebody on a modulator therapy, you are monitoring and not saying, oh, we missed that, we don't know what's going on. Trypsin can also be helpful if you're monitoring it consistently, not a one-off value. And I think we just have to focus on an individualized approach for our patients, see what else is going on, monitor their growth, their weight gain. Vitamin E as one of the fat-soluble vitamins might be a little more associated with a degree of malabsorption than, for example, A or D. That's just been our experience. And I think it's just important to really take an individualized approach with the patient. And that's not to say you can't repeat that elastase a little sooner. Also take into account, obviously, when the age of that patient, and maybe for those that are on earlier therapy, we might be saying, let's do elastase a little sooner because we might see more recovery. So I'm really excited to see data coming through. So at the very least, we have some guidance right now that's coming out.
Yeah, that's great. Another theme of questions was regarding pancreatitis. We know from the work of the late Dr. Dury and many others that people who are pancreatic sufficient are at high risk of pancreatitis. And so as this pancreas function is returning, how worried should we be about pancreatitis, and how do we recommend approaching that when symptoms are changing for people?
I think we absolutely engage our GI physicians and make sure they're savvy into the latest modulators, make sure they appreciate that and help them guide on when to test and assess in terms of pancreatitis. But it's a very real outcome that can, so let's talk about the PI group. Unfortunately, that could be happening. I didn't come, and if anybody in the audience has some case studies on that, that would be great to review. I think there's perhaps those who are PS may have less pancreatitis with an improvement, but I don't know that we have a full idea of patients who are going to PS from PI, but it's something that we should absolutely be considering and measuring enzymes so that we have an appreciation of what's going on. Mm-hmm. Great question. Yeah, thank you.
For Juliana, we had a couple of other questions too. One of them was the trends of overweight and obesity in CF people that we're seeing or starting to see. Are those, in your experience, happening in other countries in addition to the US? I think that might be in reference to the Italian group in Dr. Stalling's study.
Sure. So there is some data on overweight and obesity emerging in other countries as well, even going back to around 2005. We started to see this in the UK and Italy and Spain and in Canada. And I think that, Dinah can probably speak to what she's seeing in clinical practice in Canada and perhaps how that compares to the US. As far as the rate difference between what's happening in the US compared to other countries, I'm not sure that we have all of the data readily available. Be able to look at that side by side, changing everywhere right now.
And then another question I've had, are there specific individualized counseling tips that you have starting modulators regarding the quality of fat that they're eating?
Yes, definitely. We do try to make individualized recommendations based on patients' preferences, but we do also highlight that people with CF are living much longer now, and we really don't know how a fat diet or a diet high in saturated fat is going to affect cardiometabolic health. So we are moving towards recommending the healthier fats and the more plant-based fats, because that's what we're seeing and doing in the general population. And it's also worth noting that I think there's this misconception that patients have to eat just massive amounts of fats to take their modulators. And I think that can sometimes be driving the unintended weight gain. So we also do try to make some individualized recommendations about, you don't have to eat 30 grams of fat twice a day when you take the modulators. You might be able to get away with something a little bit lower than that, that still helps you maximize the absorption of those meds.
Yeah, that's great. And then as a question from a registered dietitian came to see if you expect any changes in the CF classification of risk. Right now, we use the goal of BMI above the 50th percentile, but then we don't really classify risk when it hits the 85th percentile or higher. Do you expect a change in the guidelines from that standpoint?
Right. So this has been a very rich discussion that we're having in the nutrition community, and I think at the CF Foundation as well. And I know the foundation does intend to put out some type of nutrition guidance document in 2022. I think it'll take a little bit longer to do a guidelines update because we really need to look at registry data and compare to CF outcomes and see if these old BMI goals of the 50th percentile and 22 and 23 in adults, if that really holds true still. So I think that, again, using some things that we apply to the general population might be a little bit more appropriate in CF now. If a child's BMI is coming up on the 85th percentile or exceeding the 90th percentile, I still think that I would consider that at risk, just given what we're seeing in clinical practice, even though we might not have the guidelines or the evidence moving as fast as what we're seeing in practice.
Right.
Is like, as far as developing guidelines, is that right now we're in still such a state of flux.
Yeah.
Everything's changing. So it's really hard to get all of the data that we need right now, because anything that happened 3 years ago is old data. So I think it'll, as Juliana said, it may be a while before we can see some sort of steady state so that we can actually develop guidelines.
Yeah, absolutely.
I think with that, it's really important to just keep in mind that your recommendations for patients in the clinical setting should be highly individualized. I can't emphasize enough, there's like no more one size fits all diet, and a healthy weight for one patient might not be a healthy weight for another patient, depending on all these other markers of health that we have besides weight and BMI. And Dr. Alvarez did a great job covering all of that in her talk. So I think just doing more comprehensive nutrition assessments and taking an individualized approach is kind of what we need to do until we have, more evidence and these updated guideline recommendations.
Absolutely. And then that kind of brings me back to Dr. Alvarez. A question had come up for you in terms of the adiposity question. Do you suspect that there might be more insulin resistance than necessarily CF-related diabetes in some of our people who might have extra adiposity?
Historically, insulin resistance, with regard to risk for CF-related diabetes, it's been an issue of insulin secretion or a lack of insulin secretion, and insulin resistance was sort of put on the back burner. But there's work out of Canada now showing that the insulin resistance, especially in our adults, it might actually play a role in CF-related diabetes, or play a more prominent role than we previously thought. And if we look at the type 2 diabetes in the obesity literature, adiposity, absolutely, visceral adiposity, total adiposity, does play an influence on insulin resistance. So it's something that we need to study specific to CF, but it's definitely a possibility.
And then what about skeletal muscle versus fat-free mass? On the DEXA scan, you can get limb-specific muscle mass, which there was a quick question on how does DEXA measure body composition. If you can give just a quick snippet on that, and then tell me about what your thoughts are on measuring those, skeletal muscles in limbs versus fat-free mass in general.
Sure. So DEXA is it's considered it's a 3-compartment body composition assessment, and so it can differentiate between fat mass, fat-free mass, and bone, or skeletal muscle, fat, and bone. And what it does, really briefly, is patients lying there on a table. It emits very low dose X-rays, and there's a receiver on top, and our different tissues, just based on their density, they have different attenuation values. So we can detect the differences between fat, muscle, and bone based on how those X-rays go through the different tissues. What was the second part of the question?
Is the skeletal muscle in limbs versus fat-free mass overall? Do you think there's different significance to that?
Right. Well, I think fat-free mass incorporates skeletal muscle and bone and all of these and organs. It really depends on what tool we use. So clinically, we can't do a DEXA scanner in at every single visit to assess all 3 compartments. So what we could use are other tools such as bioimpedance analysis, but that only differentiates between fat mass and fat-free mass. But that's not to say that looking at fat-free mass is important, because bone is just as important as skeletal muscle. So all of the components of fat-free mass are very, very relevant and important to look at.
Yeah, and I really think that speaks to some call for a tool that can give us a functional assessment of body composition a little bit more easily than what we have available. And I think that in the future, maybe that will also be incorporated in the guidelines. Some questions have come up for both Dinah and Candy regarding their experiences in providing acid suppression with pancreatic enzymes, whether it's using PPI or H2 agonists. Especially worrying about PPIs and risk of infections.
So we've gone away from that. I remember a time when a majority of our clinic were just on PPIs or antagonists with no real evidence. We've gone really away from that because of the evidence coming out for increased risk of infections, pulmonary infections with their use. And I'm excited about the US study, which I think has completed enrollment. So we should be seeing some data on that. But we go to what we do for patients who are unresponsive and at a maximum dose. We do introduce still the unprotected enzymes. So we know that, well, that some of those unprotected enzymes might be destroyed by gastric acid. We know that some still work. And so we've been taking that approach. And I honestly can't remember the last time we used a PPI other than for perhaps reflux to help treat. I'd be interested to know what Candy's experience is on that.
Yeah, I think that, so I'm in the pediatric clinic, so we have a lot of sort of physiologic reflux, which we also are trying to move away from using PPIs for our infants with physiologic reflux. I've been trying to take patients off of these medications. Some of them have been on for a long time, since prior days, and no one really understands why they're on them anymore, especially when they have a modulator introduced where we see that they can help with the bicarbonate secretion. I think we are still in the pediatric population using them when you're on max dose, at least in our institution, when you're on max dose PERT therapy, to see if we can get a little bit more growth in the patient who's failing to thrive, as opposed to sometimes using the other PERT enzyme preparations. But I really am trying to use little to none of those, if at all possible. I find myself peeling them off at a greater frequency than putting patients on them.
Yeah, I would say that clinically that has been my experience as well. It's always on my theoretical list of issues that might be going on if pancreatic enzymes appear not to work, but I hardly ever really find it in practice. More questions for Dr. Alvarez. Is hand grip strength a test that can be used in clinic, or is this just a research tool?
And I think it's a great way to monitor trends. Right now, though, there are not any specific cutoffs for what a good hand. There are some that the manufacturers for individual machines can provide that can help to provide a resource. But as far as set guidelines go for hand grip strength, they're not necessarily universal. But I do think it can help to monitor trends in strength and function.
And then could you comment a little bit on the difference between lean mass and fat-free mass? There can be sometimes small differences.
Sure. The DEXA report will give you an estimate of lean mass, bone mineral density, and fat mass. And it is very, very minor difference, but lean mass does not include bone mineral density versus fat-free mass will include the bone mineral density. So if you add up the lean mass and the bone mineral density, usually it should equate to about fat-free mass.
Thank you. I also had a question about linear growth. Now that we're going to start, and this is a question really for anybody who wants to jump on it. Now that we're going to use the modulators at younger and younger age groups, are we going to finally start to make some headway in the stunting data? We have made dramatic improvements in the CF community in the weight gain and BMI, but not as much in linear growth. And so then how do you foresee that changing in the future? And how would that help our people who are living with CF not worry too much about excessive weight gain, as they're hopefully going to have better linear growth in childhood?
So I know we've seen improved linear growth with Ivacafter, which is our other highly effective modulator besides ETI. And, once ETI is improved or approved for these younger populations, I know there's already an observational study going on in the pediatric age range that is already approved. I think we'll get some exciting data on linear growth out of that. And I like that you highlight that if our kids are maybe reaching their genetic height potential, perhaps overweight and obesity may be less of an issue. As an adult clinician, I do think about how that doesn't help my adults very much, though. But I am very excited for hopefully seeing improvements in linear growth on ETI.
Speaking of your adult patients, another registered dietitian had a question about a lot of her patients or his patients gain approximately 20 to 30 pounds, right, as they start the modulator. And one of the ways this person has been able to help is to do carb counting for these people. Is that a method you've used, or what other methods have you used to help curb maybe the initial potential excessive weight gain?
Yeah, so that's an interesting method to use. I think about half of our patients, particularly the ones that have diabetes in my adult population, are already pretty familiar with carb counting, because that's the typical, treatment for CF-related diabetes, is that basal bolus regimen with carb counting. I haven't used it a whole lot in patients that don't have diabetes, although I certainly think that if it was something a patient wants to pursue, it can be an effective method if they have excessive carbohydrate intake. I think, again, it's just really taking that individualized approach. With some patients, I think they're eating in excess of total calories. Some patients might be carbs or fat. And we really just have to do our due diligence and understanding what patients are doing in their day-to-day life, and taking good diet histories and making recommendations that are in line with what they're able to do based on their preferences, their culture, their life situations. But that is really interesting that someone out there is using carb counting and finding it super effective for preventing obesity. And I'd love to talk with you more about that offline. Please message me.
That would be great. And then a question for both you and Dr. Alvarez. For clinics that may not have an exercise physiologist, what are your tips on helping people create safe, healthy, effective exercise plans?
I think there are general guidelines that are available for just as in diet, for the general population that we can start with. Also, physical therapists are very well schooled in these exercise prescriptions as well. So I think those are both two good places to start.
Yeah, I agree with both of those things. We're very fortunate to have a physical therapist on our clinic staff, and he's phenomenal, and he gives our patients personalized exercise plans, and it's been really effective. And I think even if you don't have a clinical physical therapist on your CF team, there are avenues in reaching out to, the university most closely associated with your program to see if anybody has an interest in CF, and the physical therapy department might be interested in working with patients clinically.
Yeah.
If I could just add to that, I think it's important whenever I see patients, I always ask them, or often ask them about their exercise and activity. They just go together. And I think that just supports us as a team, and recognizing that we all have our expertise, but they do cross over. So, and it's helpful for me to know what I can encourage at that level, and to also support our amazing physios on our team.
That's great. That's great. And while we have you, Dinah, there's a question about the trend of vitamin E in people on modulators. You've made this very astute observation about it being the most correlated with malabsorption. Do you see it skyrocket in people on modulators?
So sorry if I misled on that. It's more in general, not just people on modulators, but I just find that vitamin E might be a better indicator than the others of if there's a degree of malabsorption going on, just because vitamin D and A are separate. They have other things that can affect the serum levels on that note. I also saw there was another question, I think, on enzymes, and if you could read, I'm happy to answer that one as well. What should a clinician be aware of, if I might answer that one? And I'm happy to hear what others say. Do you think you could read that one out?
Yes. So whether or not a person needs to take enzymes is a huge determination. So
Yes.
as interpreting fecal elastase results, what nuances might you need to be aware of?
So elastase is good. It does not give you the degree of malabsorption, and it can trend and go up and down, especially in those that are changing their function. We used to often, as many people know, sick kids use a 72-hour fecal fat to quantify that degree of malabsorption. It's just unfortunate. It is a 3-day test that requires families to conduct it. And we actually use those studies to help determine our fecal elastase cutoffs. So unfortunately, I think it's going back to clinical outcomes, monitoring weight growth, abdominal symptoms as well, and individualize that to that patient. So right now, we don't have that great qualitative test.
That's great. And to clarify my previous question, my question was, if people are taking modulators and fat-soluble vitamins at the same time, all of a sudden they're having this improved absorption, do you worry about toxicity of some of the vitamins that may have previously not been absorbed?
I think the only one is if they're taking other vitamins. We usually ask all those questions, but sometimes patients on their own will increase and change and add some vitamins. And right now, I think it's just the A that I would be worried about, not any of the others that I've seen. But I'd be interested to hear from the others if what their experience has been, especially in the adult world, perhaps.
I can speak to that a little bit. We have not seen any vitamin toxicities develop in my adult population since starting modulators, even with all of our patients continuing their CF specific vitamins. We have some patients ask if they can come off those CF vitamins. And so they'll come off and we'll recheck a few months later. Some of them develop their vitamin deficiencies again, others stay normal. But it's important to consider that in these CF vitamins, the form of vitamin A that's used is mostly beta carotene, which is, far less toxic than preformed vitamin A. So like Dinah said, I think unless somebody's taking an additional vitamin A supplement that's retinol, I don't think it's something to worry about.
Yeah. It's important to continue to monitor them over time for the deficiencies in particular if people stop their vitamins.
Right. Vitamins or enzymes for sure.
I think that those were most of the questions that we have. Again, with regards to the body composition changes, that's for Jessica, was there enough data to know if pancreatic sufficient versus insufficient people were affected differently?
I think one of the questions was regarding one of Dr. Susanna King's studies, and it was an Ivacafter study, and I believe it was about 90% of her patients were pancreatic insufficient, so it was hard to tell whether adjusting for that would have made any significant differences.
And then there was a question about, do you think we need to be using more advanced scales that can tell us a little bit more about different body compartments and water gain versus others?
Sure. Yeah, I think I think, as I mentioned in the talk, there are limitations to a lot of our body composition assessment measures. One thing that I didn't say, so one of the easier, I think, could be more clinically relevant, but has not been validated in the CF population, is bioimpedance analysis. And that would give us differences between fat mass, fat-free mass. It might even tell us something about water. But the range of accuracy and pricing on these bioimpedance analyzers is out of control. So we can see a $500 cheap machine that you see in the gem versus a $20,000 bioimpedance analyzer that you'll find for research purposes. So I think it really depends on what machine we're using. But bottom line is we need to be able to validate these measurements specifically in a cystic fibrosis population across all ages. And I think one of the limitations here is that there's still, even outside of the CF population, there's still a big lack of knowledge on standardization for body composition, at least on bioimpedance analyzers.
Yeah, absolutely. Okay. Well, what about low FODMAP diet, Candy? Is there any role for that in CF?
I think there is definitely a role for low FODMAP, so fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which these are the more shorter chain carbohydrates that apparently, like the small bowel, has a hard time really absorbing these, and then they can contribute to this IBS-like symptoms. And it's been a diet that's been effective in, sort of standard IBS patients. It's a hard diet to follow. So if you think following a gluten-free diet is hard, then FODMAP is going to be much, much harder, actually. But for the dedicated patient, it can be really great. I think the problem with IBS in CF is that we have a lot of things that we can sort of contribute GI symptoms to in general. And so I find myself going back to like physiology and thinking, well, is this fat malabsorption? Is this just a function of, dehydrated bowel? And so also I think that, especially in the younger patients where, we monitor that growth so closely, sometimes inadvertently the foods that give them those calories and things can contribute to the burden of these problems. And so sometimes I think it's going back to basics and looking at that 24-hour dietary recall and taking the Takis out and those things and thinking more about, the dietary guidelines. And I found myself doing that and then thinking about malabsorption, more commonly than getting to the point, at least in a pediatric patient, where a FODMAP diet would really be necessary, or, it'd be really hard to implement as well in a child. But I think maybe more so in the adult patients. I'm not sure what the experience is like in other centers if they're having their patients that want to follow it. But yeah, I think it might have more of an effect once we see what these CFTR modulators can do and we take some of these other variables out of the question. Maybe then we'll start to be using more of the medications that we're using in the general population, more of the diets that we're using in the general population for IBS-like symptoms.
Yeah, absolutely.
I fully agree with that, and a great segue. I'm so excited about the potential. We're already seeing the evidence that the microbiome is going to be changing in our CF patients, and that will affect so many things, including immunity, their symptoms. And I think when I think of the physiology, I think I'm going to be more prone to recommending more high fiber foods, which I've been reluctant in the past because of potential DIOS with some of the patients and a sluggish bowel. So I think thinking of that, and if the modulators are going to improve it that way, and then support a healthier gut in general. So we might see some changes in terms of motility and maybe just, relieve some of these symptoms. But time will tell, because each of us just have a small group in our clinics, right? And we're waiting for more guidelines, but I'm pretty excited for our patients on that front, because I think we will be able to modify some of our approaches in a much healthier way too.
Yeah, absolutely. And along those lines, this is a question for you and Juliana as well. Have you been seeing significant dietary changes or dietary habits in people starting modulators with or without counseling? And then if you are needing to recommend dietary changes, how is the sense of readiness that you're seeing in people?
I think readiness for change is variable. We have some patients who immediately make changes to their diets on their own without counseling because they don't want to gain weight, or they're really excited about the weight gain, but they want it to be the right type of weight. And we have been seeing some dietary changes in these patients who, particularly the ones that have had counseling in clinic about eating a general healthful diet rather than the, legacy CF diet of kind of eat whatever you want as long as it's high calorie and high fat. And the study that we did at UAB and the nutrition sub-study to Promise, we got 3-day diet records, and we were actually able to measure certain dietary components. And we found that although the overall diet quality did not change in the course of our study, that patients did reduce their refined grain and added sugar intake. So I think that some of the clinical counseling we're doing is making an impact. And, I think patients are also taking it upon themselves to try and eat a healthier diet, particularly if they're unhappy with the weight that they've gained. But I think it's really important to note that, behavioral change is hard and it's complicated and it takes a really long time, especially with something as complex as dietary intake. You can't overhaul your diet in 1 month and expect that to be a sustainable change. So it's really important when talking to patients, particularly people who've been counseled to eat in a way that is not in line with the messaging that the rest of us have heard about a healthy diet for our whole lives, is that behavioral change is slow and it's most effective when we go slowly in increments that are manageable. But I'd also really like to hear Dinah's perspective on this question, since she's also in clinical practice.
Yeah, we definitely our families are changing with the times, and with in Canada we got a new food guide a couple of years ago, which is plant-based proteins and a healthy plate, which you've had in the US. So we've definitely had more questions about that, from the kids themselves and the teens themselves that are wanting a healthier diet. And there's absolute great opportunity, especially in those that are wanting to make a change, and helping them make different choices that are high energy, and using, I've always recommended a variety of fats in their diet, not just staying with butter, but using different kinds of oils. And I find that response from families is pretty good in that regard. And I think we still have ways to go in general to get our diet in a much healthier zone than it is currently right now. But I do sense that our families are asking more questions about healthier choices. That's for sure. Yeah.
Something that sort of struck me, Dr. Collins, you mentioned trying to increase more fiber in the diet. There were conversations yesterday. Amanda Leonard, dietitian, made a great point that, maybe we can just promote fruits and veggies in our population. That's a great way to get added fiber, decrease in some of these saturated fatty acids. So it's like Juliana said, small changes, add some apples in there.
Sounds great. I think we just have a couple of minutes left. So with that, I wanted to just thank each and every one of you for your contributions to today's symposium. It was really great discussion. I'd also like to thank the CF Foundation for organizing this session and inviting us to chair it, and all of you who tuned in and listened to us today and contributed great questions. So thank you everyone very much.
Bye for now.
Bye.